So in this case, we're going to demonstrate the technique of using the OrthoGrid device on a direct anterior total hip arthroplasty done for a very unfortunate 56-year-old gentleman who's had bilateral lung transplants and has been on very high-dose steroids for a chronic period of time as a result. This led to AVN in both hips and collapse of both of his hips and very severe arthritis upon presentation of both hips. Normally I would have considered doing these bilaterally simultaneously. However, given his bilateral pulmonary transplant status, I didn't want to put him at any excess risk from a pulmonary or cardiac standpoint in doing bilateral total hip arthroplasty. So we've done them in stage fashion, or planning to do those in stage fashion, this procedure being the first of which. If we look at this x-ray, this is his standing AP pelvis once again, and we can see that again, the first thing we'll draw is that trans teardrop line and try to get it. His teardrops are a little bit difficult to make out given the severe osteophytic nature of his arthritis, but if we draw that line and then try to get a sort of a halfway happy medium between the trans teardrop and the bottom of the obturator foramina, you can see that his line lands, I'm going to move that up a bit, lands slightly above the top of his pubic symphysis, which is different than our last case. So he's more of an inlet rather than sort of a mix of an inlet and outlet, and he's definitely not an outlet pelvis. And you can see that he looks like an inlet pelvis, as you can see right into his pelvis quite well. And so this line helps us intraoperatively, again, using the grid and fluoroscopy. We'll try to simulate that position. The other things you can see is he's got large osteophytes all the way around the cup, a very deformed head and neck, and his hip is quite shortened. If we then drag this trans teardrop line down, you can see that his left hip is quite a bit shorter than his right, probably about a centimeter shorter, but his right hip is also severely arthritic and shortened as well, and so it's hard to know where his hips started and where we need to put them. But I know if I'm going to do them in stage fashion, I would do his left first, and I would try to lengthen his left more than the right so that when I come back to do the right, I have the ability to lengthen that right one to compensate for this severe arthritic degeneration. So those are things I see. I also see that he's got quite a bit of roll to this pelvis when he's standing straight up, and it looks like he's got no offset on this femur, but a fair bit of offset over here, or at least a neck shaft angle. It's more varus here and more straight up and down here. With that appearance to the femur and the roll of the pelvis, and after examining this gentleman and seeing that his lesser profile is quite bigger over here, you know that this hip has a pretty significant external rotation contracture, which throws off your templating in terms of your offset. And we'll see how that played in this case. Nonetheless, I'm still going to template him to see if my parts seem to fit very well. And I will sometimes template the operative or the non-operative side as well to see how they would fit. But here, when I templated his hip, you can see that my cup position, I decided to place it right down to the teardrop medially in order to tuck it underneath all of this erosion that he has superiorly. You can see also that I have a standard stem templated here, not an offset stem, which in his case, this seems to work out right now for his offset, but we know that he's in an external rotation, and we know that probably I'm going to need a more offset stem, either a high offset or a KLA stem in this Karai, in order to make up for the offset that will probably come into place when he's not in that externally rotated position. But we'll see how it plays out in the surgery, and I'll show you those films. But again, here's all of my component positioning and component size information that we have preoperatively to help us in surgery. And so we'll move on to our fluoroscopy of this case. We'll start again with our cup placement as we usually do. So I start by adding some tilt and just guessing so that you can give the patient sort of a little bit more of a halfway between an inlet and an outlet, and then we're going to try to match the patient's standing AP pelvis tilt. Gosh, our rainbow looks pretty good right there, huh? And I think that that's a pretty decent grid shot, and actually it represents our tilt pretty well because, you know, that trans teardrop line is above the symphysis, top of the symphysis. I think our abduction and anteversion look pretty good. You know, we just got to get way down in that hole. Shot. Okay, I'm going to get the straight inserter because there's just no way without it on this dude. shot. Okay, I like that picture better. And I think our overall position in terms of cup position is pretty good. I reamed a little high in him, which sort of I knew would happen because he's eroded some bone up top, you know. In this case, I'm looking at the grid. For this one, I've slid the grid over toward this cup as a check of my cup position by placing the grid just so that I can see the teardrop on the other side and I can see the teardrop on this side. My trans-teardrop line is lined up with the teardrops, and I can see that I've adjusted his inlet-outlet or his pelvic tilt such that that line is above the top of the symphysis. Again, roughly about the same height, if I move this up to the trans-teardrops, as it was here. And I've simulated that position with my fluoroscopy for my tilt. I'm looking at the coccyx, that it's centered over the symphysis. Here I can't check the ischia both sides because I'm centered over this cup, but nonetheless you can see that the grid is lined up with the pelvis and the pelvis is rotated correctly. Again, I look at the cup insertion handle, which is straight compared to this 45-degree insertion line, and that should be slightly less than parallel when I'm starting my insertion. I like this cup ellipse in terms of anteversion, but I'll check my anteversion with bony landmarks after I've got the cup in. Here again is that lateral of femur once I'm to the femur to make sure that my broach is going down the canal, which I'm happy with that. And then we get an AP shot. This we would normally get at the broach. So that's a pretty decent grid. You know, and so my lengths right now are actually pretty close, but he just needs a lot more offset. And I want to make sure that I include the entire femoral stem. That shot basically lets me look at one, do I have any femoral fractures that I wasn't expecting? Make sure that there's no fracture of the greater trochanter, make sure everything looks good, and then make sure that I'm not in too much varus or valgus, that the stem is down the pipe of the femur on an anterior view. And then I look at the size of that stem in the canal. I intentionally will broach to one size within where I think I'm going to be. So if I think I'm going to need a size 13 stem, I'll stop at about an 11 or a 12, even if it feels like I could go bigger. And I'll get that shot broach or trialing there to look at how big the stem looks in the canal to know for sure that I can go up a size and not be too tight. So that looks like a good neutral pelvis shot in terms of his sacrum, in terms of the symphysis, in terms of his two lines there. So, you know, lengthwise right now, I'm a little long, which we're intending to do because this guy has very bad arthritis on the other side and he's already scheduled to get his other side done. I did not do him simultaneously because he's had bilateral lung transplants. Right now his offset is just a little under offset on the operative side compared to his native, and his length is maybe just long by, oh, I'd say 5 millimeters. This was with my final implant in place. What we did when we first broached, we broached and we put a standard neck on this gentleman, which is what we had templated, and we found that we did not have nearly enough offset. And so we then trialed with a KLA neck length, or the neck angle rather, and that gave us more offset, and that seemed to recreate his offset nicely with the neck length that we already had for our resection. And this was our final KLA stem in place. It's a little bit tight in here for the karae. I maybe could have gone one size smaller, but I think overall it will be okay. Other than here, I think elsewhere it's good. And this seems like it fits him well. And then here we were checking our abduction, adduction compared to the other side. This looked a little bit adducted, and so we adjusted and abducted it to be appropriate. And then here is our final check for our limb lengths and offset check. When we look at this image, we can see that the coccyx lines up with the center of the symphysis for rotation. We can see that the grid is lined up with the center of the symphysis, that when we look at boxes away from this vertical dark line, I'm about just shy of 2 boxes from the edge of the ischium on this operative side, and just shy of 2 boxes from the edge of the ischium on this non-operative side. So my rotation is correct in terms of roll side to side. Again, when I have that trans-teardrop line, the tilt looks great in terms of that trans-teardrop line sits just above the symphysis. And so I have a good image, and I'm happy with that image. My grid is centered, and my pelvis is in a neutral position that simulates his standing position. And so now I can look at my limb lengths and my offset. And here if I look at offset, this is again with the KLA stem, which gave us the offset we needed. We can see that my offset is at about this 3 line vertically. I'm just past it here on the operative side, and I'm just past the 3 line vertical on the non-operative side. But as we look at limb lengths, you can see that the apex of this operative lesser crosses with this second horizontal line, whereas the apex of this lesser crosses maybe just below the top line. And so I'm probably about a half a box, maybe just over a half a box different in terms of limb length. And so I'm probably about 5 millimeters or 4 millimeters long on the operative side compared to the non-operative side, which is exactly what we wanted to do. We wanted to make him longer on this side before we do his other hip replacement, which we know is going to need to be done and was already planned. And so we've lengthened him a little bit with respect to the other side, and the grid tells us our offset's correct, our cup position looks good, just slightly less than 45 in terms of abduction. I know that my anteversion looked good on my ellipse and intraoperatively looked good from the front edge of the cup, and I know that my limb length is just slightly long by probably 4 millimeters on the operative side. So that's all the information the grid gave us at the end of the case. Additionally, you can see that if you look at these grid lines, there tends to be a little bit of a bend to them. It's sort of an S-shaped curvature. Here, if I take a line and I draw a line on the screen, which you can do on your fluoroscopic unit, and what a lot of people will do, if you just draw a straight line and I were to say, okay, let's draw that line and let's make the trans-teardrop line and say, okay, there's my trans-teardrop line, we'll check it down here. But then if I look and I look at how that line lines up with these other lines, these grid lines, one, that line tells me that my limb lengths are exactly the same when I know that my operative side is long intentionally. And two, you can see that this line that I drew tends to be close to this line on the operative side, but as it goes along here, you can see that the grid lines tend to distort away from that line that I drew and are no longer straight. And so over here, you're way off in terms of the position of the line that you drew with respect to the grid lines. So this image has a fair bit of distortion in it. The nice thing is I'm able to ignore the distortion and just look at the grid lines, trust the grid lines because they're distorted in the same way that the anatomy is distorted because they're in the fluoroscopic field. But if I were trusting this, I would say, okay, that line that I drew and I didn't have the grid, I would say, geez, I'm about the same length. I need to lengthen him even more on this side in order to get it long, and I might be too long and not be able to catch up on the other side. And so let's see what our postoperative films show. And so first things I'll do on my postoperative films is again measure my cup angle. I'll do that by first drawing the trans-teardrop line and trying to verify that I have a good, pelvis line. And so there I'm lining it up with the bottom of the operative foramina and saying, okay, yeah, that looks to be about the bottom of the teardrops. And so I think that's a good line. And then I'll drag this angle line and check my cup edge here and try to drag it so it lines up right at the edge of the cup. And here I'm about 43 degrees in terms of my cup abduction. So again, it's just less than 45, which I'm real happy with. I think my cup position overall looks good in terms of its depth. Maybe a little bit high on the cup position, but if you look at this image, this trans-teardrop line lines up with the top of the symphysis, and so this is a little less of an inlet than he stands with, and as you get more inletty, you'll get the cup will drop down some, and so it may look more like where it should be with respect to the bottom of the trans-teardrop line, but nonetheless, I think his cup position is still very reasonable. He had quite a bit of superior wear, and so we were just trying to get the cup tucked into that to get some bite in the cup there. Then I'll look at my limb lengths by taking that trans-teardrop line, dragging it down, and if I look at his limb lengths, I can see that I'm probably about 5 millimeters long on this side compared to the other, which gives me a nice room to take this other side and bring him down to account for this significant wear and collapse that he's had through the AVN on this side, and get this hip lined up with the other side and hopefully restore his anatomy on this side to the side that we just did. And I think we can do that very much within reason as we lengthen this side quite a bit, and he still was not very tight at the end of the case. Stem looks good, it's lined up well, don't see any obvious fractures, everything seems to be fitting him quite well.